and looking at it, the mouse disappears when you go into the presentation mode. So I'll have a look if it's an option for when you're doing the presentation. I'll just quickly Google.
Great things often have small beginnings. A delicate journey to MASH Premier building blocks. Exploring the mystery of each new drug aids a new hope. That's our daily commitment at MASH Premier since 1986. MASH Premier has been founded to serve customers in dermatological, cosmetic, and personal healthcare sectors. In 2006, we directed our efforts towards the pharmaceutical field, starting with 15 products manufactured at our own new facility. Starting from 2009, we started a new era in the pharmaceutical market, building commercial business units for CNS and urology products. We expanded in 2012 by adding 4 new business units: GIT, antibiotics, dermatology, and OTC drugs. In order to cover patients and the market needs, we decided to construct our second facility. Manufacturing Biomed for solid cephalosporin antibiotics between 2014 and 2015 was our giant leap into the market. By launching 42 new products in the generic pharmaceutical market in 2016, we expanded our coverage over many therapeutic areas with special focus on chronic disease medications. In 2017, we started to construct our third facility on 4,000 meters square that contains a dedicated area for oncology products, in addition to the new expansion in Biomed production lines for semi-solid preparations to catch up with our growing dermatology portfolio. Also a dedicated area for sterile cephalosporin antibiotics. Now we're offering more than 185 products, covering almost all therapeutic areas as antiviral, cardiovascular, CNS, gastroenterology, antifungals, antibiotics, antidiabetics, orthopedic, dermatology, OTC drugs, urology. We have over 220 products in our pipelines under registration. Nowadays, MASH Premier is the fastest growing pharmaceutical company in MENA region, Middle East and North African region. A painstaking effort was behind the provision of hepatitis C treatment to enable each patient to be cured regardless his income level. Proud to be honored by WHO for our unique contribution in hepatitis C eradication campaigns and screening of undiagnosed patients, which helped in curing about 1.5 million patients in Egypt in 2019. We are celebrating 10 years of well-being with CNS Business Unit. It all began with Atinsera, a tamoxifen molecule in 2011, Alzexa memantine molecule in 2012, Mertimash mirtazapine molecule in 2013, Carbalta duloxetine molecule 2015, Agovald agomelatine molecule in 2016, Venlamash venlafaxine molecule in 2017, Cyclone's combination of fluoxetine and olanzapine by the end of 2018, Caesarless levetiracetam molecule, and last but not least, in 2019, the launch of Carbalta 30 milligrams. Currently, CNS MASH Premier is ranked number 4 in the Egyptian CNS market, preceding by 3 multinational companies, making MASH Premier number 1 national company. This is all due to the trust successfully built with the healthcare providers all over the country throughout the past 10 years. Physicians are provided with the highest quality products to ensure the maximum efficacy. The same trust is built with thousands of patients who are being treated successfully with our affordable and effective products. This all led to a growing and increased responsibility on Match Premier to produce more affordable and effective products, to add all of them to its huge portfolio, covering all major therapeutic areas. Match Premier. We build trust. Match Premier. We build trust. Great things often have small beginnings. A delicate journey to Match Premier building blocks. Exploring the mystery of each new drug aids a new hope. That's our daily commitment at Match Premier since 1986. Match Premier has been founded to serve customers in dermatological, cosmetic, and personal healthcare sectors. In 2006, we directed our efforts towards the pharmaceutical field, starting with 15 products manufactured at our own new facility. Starting from 2009, we started a new era in the pharmaceutical market, building commercial business units for CNS and urology products. We expanded in 2012 by adding 4 new business units: DIT, antibiotics, dermatology, and OTC drugs. In order to cover patients and the market needs, we decided to construct our second facility, manufacturing Biomat for solid cephalosporin antibiotics. Between 2014 and 2015 was our giant leap into the market by launching 42 new products in the generic pharmaceutical market in 2016. We expanded our coverage over many therapeutic areas with special focus on chronic disease medications. In 2017, we started to construct our third facility on 4,000 meters square that contains a dedicated area for oncology products. In addition to the new expansion in Biomed production lines for semi-solid preparations to catch up with our growing dermatology portfolio. Also a dedicated area for sterile cephalosporin antibiotics. Now we are offering more than 185 products covering almost all therapeutic areas as antiviral, cardiovascular, CNS, gastroenterology, antifungals, antibiotics, antidiabetics, orthopedic, dermatology, OTC drugs, urology. We have over 220 products in our pipelines under registration. Nowadays, Mash Premier is the fastest growing pharmaceutical company in MENA region, Middle East and North African region. A painstaking effort was behind the provision of hepatitis C treatment to enable each patient to be cured regardless his income level. Proud to be honored by WHO for our unique contribution in hepatitis C eradication campaigns and screening of undiagnosed patients, which helped in curing about 1.5 million patients in Egypt in 2019. We are celebrating 10 years of well-being with CNS Business Unit. It all began with Atinsera atomoxetine molecule in 2011, Alzexa memantine molecule in 2012, Vertimash mirtazapine molecule in 2013, Carbalta meloxetine molecule 2015, Agovald agomelatine molecule in 2016, Benlamash venlafaxine molecule in 2017, Cyclone's combination of fluoxetine and olanzapine by the end of 2018, Caesarless levetiracetam molecule, and last but not least, in 2019, the launch of Carbalta 30 milligrams. Currently, CNS Mash Premier is ranked number 4 in the Egyptian CNS market, preceding by 3 multinational companies, making Mash Premier number 1 national company. This is all due to the trust successfully built with the healthcare providers all over the country throughout the past 10 years. Physicians are provided with the highest quality products to ensure the maximum efficacy. The same trust is built with thousands of patients who are being treated successfully with our affordable and effective products. This all led to a growing and increased responsibility on Mash Premier to produce more affordable and effective products, to add all of them to its huge portfolio, covering all major therapeutic areas. Mash Premier, we build trust. Mash Premier, we build trust. Great things often have small beginnings. A delicate journey to Mash Premier building blocks. Exploring the mystery of each new drug aids a new hope. That's our daily commitment at Mash Premier since 1986. Mash Premier has been founded to serve customers in dermatological, cosmetic, and personal healthcare sectors. In 2006, we directed our efforts towards the pharmaceutical field, starting with 15 products manufactured at our own new facility. Starting from 2009, we started a new era in the pharmaceutical market, building commercial business units for CNS and urology products. We expanded in 2012 by adding 4 new business units: GIT, antibiotics, dermatology, and OTC drugs. In order to cover patients and the market needs, we decided to construct our second facility, manufacturing biomat for solid cephalosporin antibiotics. Between 2014 and 2015 was our giant leap into the market by launching 42 new products in the generic pharmaceutical market in
مساء الخير دكتور جمال، ازي حضرتك؟
انا وقفت خلاص. انا وقفت.
دكتور وائل اتفضل.
مساء الخير يا دكتور جمال، ازي حضرتك؟
مساء الخير، اهلا وسهلا.
كريستين.
اهلا وسهلا، ازيك دكتوره كريستين؟ اهلا وسهلا.
لو الناس دخلت ابدا وبعدين اقدم حضرتك عشان نبدا.
اتفضلي. اتفضلي.
طيب طيب تمام بيرفكت. مساء الخير على حضراتكم جميعا. انا كريستين ادوار، ماركتنج هيد لاين الكاربالتا، وفي ماش بريمير معايا اكتر من لاين، ومعايا دكتور وائل. يشرفنا ان احنا النهارده في الثيرد سيشن في الديفورميتي بلاننج كورس، ويشرفني انه يبقى الكورس ده سبونسرد باي الكاربالتا وسبونسرد باي ماش بريمير فارماسيوتيكال كومباني. اتس ا بليجر ان احنا موجودين مع حضراتكم النهارده. نتمنى لكم كل الاستفاده، ونحب ناكد على حضراتكم ان احنا دايما موجودين معاكم بكل حاجه educational تفيدكم وتستفيدوا منها. اسمحوا لي اقدم بروفيسور دكتور جمال حسني to introduce the third session today.
شكرا دكتوره كريستين. في الاول طبعا انا بشكر شركه ماش بريمير على السبورت المستمر لانشطه الجمعيه، وطبعا هي شركه كبيره وليها ادويه كبيره جدا الكاربالتا، وبشكر الدكتوره كريستين والدكتور وائل على السبورت المستمر لانشطه الجمعيه. Good evening, everyone. First of all, I would like to thank Mash Premier Company for supporting the scientific events of the Egyptian Orthopedic Association. I would like to thank too Dr. Liz Mulder and Professor Hemant Sharma and James Fernandez for participating in the activities of the Egyptian Orthopedic Association. This is the third session of the miniature of the deformity planning course organized by the Egyptian Orthopedic Association. And the first lecture today will be with Dr. Liz Mulder. She's going to speak about a very difficult topic, about the radiological assessment of deformities. Please.
Thank you. Thank you. I'll share my screen and hopefully you can see my slides. So yes, through this talk, I'm going to be talking about how and why we use X-rays to understand limb deformity, and also hopefully improve your knowledge on how we even get X-rays. What are they? So what do we use X-rays for? How are they made? Which I must say I've always been fairly ignorant about, but with importantly how that matters to us and how we use them. Because we have to standardize our X-rays in order to get reproducible images of our patients. We're going to talk about some special circumstances in how you might need to change how you get your X-ray, and some of the mistakes that we make, and some ways we can make our lives easier. So why do we need to use X-rays? Because unfortunately, we don't have superpowers like Superman. My son is obsessed with superheroes and asks me on a nearly daily basis, Mum, if you could have any superpower, what would it be? And I always tell him I would have X-ray vision. And then he tells me I'm not allowed that one. I have to choose something different because I can't always have that one. And that one's Superman's. But yeah, if we had X-ray vision, our lives would be so much easier, because when we meet a child like this, all we can really say is, oh my goodness. We can't really say where the problem is or where we're even going to start to unpick a problem like this. So we need special X-rays. So.
Sorry, I can't see your screen, so I'm not sure others can or not.
Oh, okay. Can other people see my screen?
No, doctor, can you share it?
Oh, sorry. Let me start again.
You have to share the screen.
I didn't click share screen. You are right. Thank you very much. I only clicked on starting the presentation. So you have, oh, it's that last share again.
Yes, that's it.
Yeah. Now. Oh.
We can see now.
Yeah, but now I can't move my, oh no, I can. I want to go back. There we go. You missed my Superman. So
Very important. Yes.
Very important, because you need to know why we don't have X-ray vision. We're not like Superman. And you missed the child who I was saying that yes, if you need X-ray vision to understand a patient like this. You can't look at that and predict where you need to make your osteotomies, or even how you're going to begin on correcting a deformity like that. So this is how X-rays are made. Who knows? Who knows what's going on in that machine? And the point of this slide is you really do not have to understand all of this. The important thing that you have to understand is that the X-rays are made from the tube or the source. I call that the machine. And when the X-rays come out, they diverge. This is the important thing. They don't travel in a straight line, they diverge. And because of that, when they hit the object or your person or the limb, whatever you're X-raying it, because they're diverging, you end up with a magnified image on the detector. So this is what you have to understand about how X-rays are made, is that the X-rays diverge away from the tube. And we have to understand this because if we are trying to analyze complex deformities, we need to understand, the first thing is, on our resultant image, the projection is bigger than it is in real life. So you can see here, the resultant image is bigger than the object. Now, this is a simple ratio maths. The magnification is basically equal to or proportionate to the distance between the source and the detector divided by the distance between the source and the object. And why is this useful? Basically, if we increase the source object distance, we can decrease the effect of magnification. And if we get the patient as close to the detector as possible, we also will decrease the magnification ratio. And that has further implications. So for example, if you move the patient too close to the tube, the resultant image is much bigger than the real thing. That magnification effect is greater. Also, if you've got a fat patient, your magnification factor is much bigger. Or for what we might be doing to patients, if you've got a frame around a patient's leg, the magnification is greater. So that means that, for example, the patient that you X-rayed before operating, you may have a different magnification to the one after, even if you were to do everything else equal. And you have to bear in mind these points when planning your X-rays and also when analysing your X-rays. So you need to standardize how you perform your X-rays. Every hospital is different, every system is different, every hospital has bought a different system, and not everywhere has sophisticated systems. I'm well aware of that. This is our system in Hull. We've got digitized images. Otherwise, you can still do 3 separate X-rays and literally sellotape them together on your films, or you can do 3 separate X-rays and digitally stitch them together. But our system is more of a scanning system. You need to position your patients. Now, standard X-rays are taken by the radiographer with the feet forward, whereas what we want, and I'll explain why later, is the patella or the knee facing forward, not the feet. And then for the side view, you do a turned side view with the pelvis. You can see the hip here is externally rotated compared to the right hip, and that is to externally rotate the left leg so that you try and see from the hip down to the ankle, if at all possible. It's very hard to get good lateral views. And now this is the scalar ball, and you need to know how big your scalar ball is. Ours is now a standard 25.4 millimeters. And you can see here, it's in the plane of the bone. And it's also here in the plane of the bone. So it's the right leg that's being X-rayed here. So it needs to be moved when you move from the AP to the lateral view, so that it's in the same plane as the bone. And the other thing is, because we've got knee forward for these X-rays, when you do a 90-degree X-ray, is also knee forward, so that you've got 2 perpendicular views. And that's very important if you've got an angular deformity, so you can work out where the apex of your deformity is. I say you need to know the size of your scalar ball because I'd been working as a consultant in our hospital for about 5 years before I learnt that the size of the scalar ball that we used in one of our hospitals was different to the other. We had a 25mm and a 30mm ball. We're now standardized. So yeah, just don't assume it's 25.4, always check. And what you can then do, if you go back to the maths from the earlier slide for the magnification multiplier, you can work out the object size in real life. This is back to when we were using a 30mm ball. So I knew this was a 30mm scalar ball, and I divide it by the size I've measured on this film. And then any further images I make on that X-ray must be multiplied by that ratio. There's other ways you can do. If you've got packs, you can use the ratio tool on packs, but that gets a little bit confusing. Obviously, if you have trauma CAD as well, that will even help you find the scalar ball, and then you can tell it how big your scalar ball is. You can use metalwork on the patient as well. If you know, say, the diameter of a nail or the size of the screw in an 8-plate, that kind of thing, you can use that as your magnification marker. And given that that's in the plane of the bone, that's actually probably more accurate, and you're not relying on your radiographer doing it. So yeah, for example, each time I did this with all the different magnification markers, I did get a very slightly different reading, but it's more accurate than not taking magnification into account. So this is now to illustrate why we must have the patella forward. You can see in this X-ray, the patient hasn't got the patella forward. They haven't got the knee joint forward. The patella is sat laterally here and a little bit lateral here. Patient looks like they've got a valgus leg, and the X-ray has literally just been taken in that position. And this is where the mechanical axis, for those of you with us the other evening, the mechanical axis is the line drawn from the center of the hip down to the center of the ankle. And this is passing lateral, but within the knee joint. If we then reposition the patient with the patella forward, and sometimes what I do is I draw the patella on the patient before they go round to X-ray. And I say to the patient, make sure you show the radiographer and tell them that this needs to be forward, even though I write it on the request every time. So if we put this kneecap forward, you can see that the foot now is very internally rotated. So the patient doesn't naturally want to stand like that, but it gives us a very different view. And you can see, you know, clinically how much more valgus that limb appears, but also when you draw your mechanical axis. And here, look, the patella is forward. And this is important for many reasons. One is you can then standardize and get a patella forward lateral view. Two is it tells you that there is internal rotation here, and you might want to account for that when you do your deformity planning and deformity correction. And it also means that later, when you start, if you alter this limb and you want comparative X-rays, you've got a standard method of comparing those X-rays, and you can properly see the difference, and you can properly measure any of the deformity on this limb. Problems arise if this last X-ray here, if we look at this, if this was actually a subluxed patella and a subluxed in extension, which can happen, then you might not choose to do a patella forward view, but a knee forward view, in which case you ask the patient to flex and extend the knee to find the hinge of the knee and face that hinge forward. So just something to be aware of there with subluxed patella. But otherwise, patella forward is the simplest way to standardize your X-rays and trying to get your picture from the hip down to the ankle so you can draw that mechanical axis. There's no scalar ball on those images. I assume I've cropped it off, but otherwise, of course, you would want that scalar ball. Oh, there we go. It's down there. So going further to this, you can see the problems with rotational deformity. And again, how different those X-rays can appear. So with the patella forward view here, just have a look and confirm that you have got an AP view of the ankle and an AP view of the hip. If you haven't, it means that there's rotation in that limb, and you may want to get separate X-rays of both the hip and the ankle so that you can have a look if there's any angular deformity in that area and whether the joint orientation lines are normal. because otherwise, again, there might be a secondary deformity there that you have to further correct. It will also give you some idea regarding the rotation within that limb, although it's always very, very difficult to quantify rotational deformity. But yeah, essentially patella forward views, if you're not seeing AP of the hip and AP of the ankle, then there's rotation, and you will then, if you're doing proper deformity planning, need separate x-rays of those areas just to have a look and have double check for any deformity. So for example, assessing here in this patient, it's extremely difficult to work out what degree of rotational deformity there is where in that patient. The commonest question I ever get when I deliver this talk is, how do I assess rotational deformity? And there just isn't a super guaranteed simple method. It's back to basic clinical skills. The best way is always to have the patient prone on the bed and have a look at their tibial torsion. Femoral rotation, as you know, is then very difficult to examine and feel for the prominence of the greater trochanter. But ultimately it's clinically, and you will also find, if you're correcting a big deformity, that as the varus or valgus improves, so does the rotational deformity alter. So yeah, that's why personally I'd always advocate circular frame fixation in any complex deformities like this, because you can gradually alter the patient's limb, and ultimately they will tell you when they feel right. So I don't have a quick and easy fix. You can do CT scanning. I think, to be honest, this is much better, more easy, simple for the knee surgeons to use if there's no angular deformity in a knee and they're looking for patellofemoral tracking and to alter the rotation of a limb in order to change tracking. You need specialist software, you need radiologists who are happy to report and to do the overlay of the imaging and to give you the angles. And I think ultimately, for our sake, it's a combination of spotting the difference on the AP views of the joints on the long leg films, and also using your clinical skills to assess the patient. Other pitfalls to be aware of is patients with limb length discrepancy. And we ask all of our patients to stand on a block on the short leg to equalize their limb. That's because of patients like this, where it would appear that that right hip is uncovered. And that's because of the pelvic tilt is tilting the pelvis. Of course, it could then turn out to be a fixed tilt. So you would want to make sure that with that leg equalized and a block under that side, that there is better cover of the hip. And interestingly, this doesn't completely cover, but it is improved. You find that especially children develop all sorts of tricks to disguise their limb length discrepancy, not for cosmetic reasons, just for functional reasons. Life is better with a level head on your shoulders. And so they would often, for example, flex the long leg at the knee. They may put the long side into varus or valgus. They might tiptoe, of course, on the left side. There's lots of things that children do to cheat. So if you don't equalize their leg lengths as much as you can with blocks, you won't have a true picture of their alignment or of their leg length discrepancy. But beware, not all children can correct, or it's certainly not all adults. So you will also discover whether you have any fixed pelvic obliquity or scoliosis compensating for the deformity, or even a fixed flexion contraction. So it's why you should always try and examine the patient, see if you can equalize the pelvis, and equalize it when getting x-rays if you can. This is alluding to one of those kind of compensatory deformities as well. So you can see this patient with a very valgus ankle has developed a varus hindfoot in order to compensate for that deformity. And again, if you don't look for these things, you won't find them. So the answers aren't all in your long leg films. You have to get specialist hindfoot views. Many different methods are described. There's lots of different techniques for doing this. But have one that you and your radiographers are comfortable and can standardize and look for routinely, to look for any compensatory deformity. And also, again, you're examining and assessing to see whether it's fixed or flexible, because the patient won't thank you for correcting this if they can't then correct within their hind foot. If that's a fixed deformity, they won't want that fixed. So yeah, you can have a look for the different views available. This is the Saltzman view. Very good always to have a standing view of your patient. A weight-bearing view is going to give you good representation, because ultimately you're correcting a patient for weight-bearing, but you do also need views that you can do in theatre. CT scanogram, somebody asked about this in the talk last week. Historically, it was used a lot, especially before people had the software for stitching together the images for the long leg films. The problem is it's quite nice to get those lovely accurate views, 67.2 millimeters and that kind of thing. It's very difficult when there's metal artifact. It's not a weight-bearing view, so it doesn't actually represent the patient standing up. You're again with something like a frame on, the patients may be hyperextending in that knee, and you can't get a lateral view. So we pretty much never use a CT scanogram now. And in fact, you can see these images are from 2005. This is a patient who we looked at last week to remind you to look for that joint line laxity. And again, if you've got any doubt about whether that's a correctable deformity, you need more x-rays. So you need to get, if you see a joint like this, you need to do varus and valgus strain to assess whether that's a fixed joint line contracture, and to give you an idea of how much any deformity correction is going to compensate for that. Now, this is one of the hazards of stitched images, and in fact, it's one of the biggest problems with getting x-rays in our patients we're correcting. This is a stitched image, and if you have a look here, they have stitched together the struts incorrectly. They've made a translation error, which in turn has made the bone appear to be much worse than it actually was. So just always sense check your images and just make sure that they have been stitched together properly if you've got digital stitching. The other problem you can see here is the problems we have with getting decent images of patients with frames on. And if you're like me, a hexapod user, you need your reference ring beam parallel. And for that, they need to use the scout beam. And you must be very careful how you're requesting these x-rays. Ultimately, the radiographers will only ever do the x-rays you request for, and asking for a beam parallel to the ring that you want to look at makes a big difference. This we've talked about already. When you're looking at angles on x-rays, you do need an AP and a lateral, and especially the deformity is often oblique, and that's why you need a standard way of getting your x-rays with the knee forward, and that's to unpick the oblique deformity and look for the rotational deformity. I think that slide was in the wrong place, because this is still sticking now on frame patients. These are 2 x-rays taken on the same day with nothing else different done to the patient. And you can see this is just a matter of how you request that x-ray. This one is clearly not being parallel to any ring. It makes no sense at all. You can't do anything with that image at all. And then as soon as we get this x-ray beam parallel to, it turns out pretty much the proximal and the middle ring, it looks like a completely different bone. And any measurements you took off this x-ray would be just meaningless. So yeah, just always be careful what you request for when requesting your x-rays, and do go back and get those x-rays redone if they're not good enough. And then between you and your radiographers, you can learn how best to communicate with each other. Again, we talked about this patient. This is illustrating that joint line contracture, and the fact that if you don't look for these things pre-op, you won't correct your deformity. Even if you correct the bones, you will still have not corrected the patient's mechanical access without causing, doing translation, which is fine if that's what you've planned to do deliberately, but you have to spot that problem in advance. This is just, it's not really a plug. I don't teach on the Baltimore deformity course, but they do have their app Bone Ninja, which is quite useful if you don't have access to TraumaCAD, because it's an iPad only app, unfortunately. It is $50, but I have been told previously, and I myself got lucky, that when the deformity course there is on, that price comes down, I think, because their delegates can use it. So just keep an eye. I think the price does fluctuate. I have used this in theatre as well to take photos of the image intensifier in theatre, because our x-rays aren't uploaded straight away to the system. So I have used it for planning off in theatre images, and you can also use it from photographs or x-ray film. And if all else fails, printing out your x-ray, planning off your x-ray, and cutting and sticking it back together is also still a fail-safe. And I still if I'm doing a complex deformity, it's still my preferred method. I think there's something about manually handling it and moving it yourself is often the best way to understand a deformity. So in summary, when you're getting an x-ray, first of all, bear in mind you're exposing the patient to radiation. So you have an obligation to get it right first time, if at all you can. Make sure that your x-ray is performed in a manner which is reproducible. And certainly the standard way to do that is with the knee forward. And it is amazing how that can alter the appearance of the limb. Remember that those x-rays diverge, and so you get a magnification effect. So find a way to measure that, and consider, especially if it's a frame x-ray, the focal point of the beam and where you want your x-ray to be focused to get the beam parallel to your ring, your reference ring. Rotation is always hard. You've just got to be very careful and think about it clinically as much as anything. And don't forget to correct for any leg length discrepancy in these patients. Okay, thank you very much. I'll hand you back.
Thanks, Dr. Liz, for the explanation of this very difficult topic, I think so. I think we'll have too many questions at the end of the session. Now I'm going to speak about another topic. Here we are. We are going to speak about the closed fracture reduction as a deformity correction. What I mean by closed fracture reduction, I mean adult long bones fracture, femur or tibia of the lower limb. Can we do closed reduction to treat the patients as a definitive treatment, not as a primary treatment or a temporary treatment? The hypothesis is, if we have a displaced fracture, we have an axial malalignment, which is exactly a deformity. So if you want to treat axial malalignment, you want to do axial realignment, so you are treating a deformity. So if you remember from the last session, we were talking about the cora, which is the apex of the deformity. Actually, if you have a fracture, the cora lies in the fracture. And the ACA, the angulation correction axis, which if you use hinges, if you use external fixator, that means the hinges. And the osteotomy, which is a fracture. We already have an osteotomy. So we can have the three players again if you have a fracture. So if you want to do deformity analysis, you want to know the site of the cora. So you draw the mechanical axis of the proximal tibia and the axis of the distal tibia, and they are going to meet each other in the cora. Here, And then you draw the transverse bisector line. And any point on this axis is the chora. And if you want to correct it, you have to do an urosteotomy here over the chora. So you have your chora, ACA, and osteotomy at the same place. And this is osteotomy rule number 1. Look to the fracture. We have a fracture of the junction of the middle and lower third of the tibia. And if you draw the axis of the proximal tibia and the axis of the distal tibia, and you are going to have the chora here. So you have too many choras. So you can correct the displacement of the fracture exactly like you treat a deformity. There is no such a difference. Again, if you have a neglected fracture, here neglected fracture, and you draw the proximal axis and the distal axis, and they meet each other in the chora. Again, if you have a proximal axis and distal axis, they are going to meet each other in the chora. So you have the chora here, and urosteotomy the site of the fracture, and we have an oblique plane because the displacement, you can see the displacement in the AP and you can see the displacement in the lateral. So this is an oblique plane deformity. Are we talking something new? This is not true. We were treating fractures as a deformity from the day one. Perhaps many years ago, we were treating fractures like deformities. If you have a fracture of the lower fourth in children, you see here, this is a child with a fracture of lower fourth, which is a common fracture of the forearm in the children. And you have this angulation. This site of angulation is the chora, or the apex of the deformity. And the osteotomy or the fracture. And when you put two thumbs and you move your thumbs, you created an ACA. This is an ACA. This is the hinge you created. So there's nothing new. It's an old concept. We were doing that for years and years. It's just the nomenclature. But actually, we are treating the fracture as the displaced fracture as a deformity. Long time ago, nothing new. But this is not the only issue. If we talk about close treatment of long bone fractures, of the fracture of the femur tibia, as a definitive treatment, it seems like we are talking about an impossible thing. It looks like swimming against the current. Why? Because if you talk about the femur of the tibia, everybody speaks about the open reduction and internal fixation as a conventional treatment. Nobody speaks about the close treatment. Perhaps sometimes in some open fractures, they talk about indirect reduction of the fractures, which is not just close treatment, because sometimes they do incisions. And they talk about external fixator as a temporary treatment. So you put external fixator for 10 days or something, just for healing of the soft tissues, which is quite unpredictable. Then you have to do an open reduction and internal fixation. So everybody has to have open reduction and internal fixation at the end. So if you speak about the close treatment, actually it's swimming against the current. So let's swim together against the current. If you have a fracture of the long bone in adults, femur or the tibia, you have a bone injury. We all know the bone injury. We know the classification of the bone injuries. You have to tell the classification of the fracture type 1, 2, 3, A, B, C. Okay, no problem. But look to the soft tissue injury. It's really underestimated. Why underestimated? Because you cannot predict the value, the size of the soft tissue injury. We have classifications of the soft tissue injury, but the severity, it's usually subjective. There is no way to measure it, no way to say that if you have this picture, what type of tissues are injured, were injured in the, how severe it is? No way, no way. There's no measurement, there's no real measurements, just the classifications or something like this, but you don't have a way to measure it, especially if you have a closed injury. Even if you have an open injury, you have the classification, all the classification, but you cannot also classify these pictures. You see the soft tissue injury. Again, if you have a closed injury and you have infected injury, look here to the femur. It's almost adherent and you have severe soft tissue injury, which again, you cannot calculate it. So if you speak about open reduction and internal fixation of the long bones of the lower limb as a conventional treatment, actually you speak about double-edged sword. This is سلاح ذو حدين. You have many advantages. Again, you do more soft tissue injury. You denude the bones. They induce avascularity, whatever the size, but it's different. So open reduction can be very harmful to the bones. What's closed reduction? Closed reduction is to correct the alignment to normal anatomical position through the manipulations without any surgical approach, exposure. So now I'm going to speak about no surgical exposure of the fractures of the femur and tibia. So we want to move the fragments from this position to that position, and from this position to that position in neglected fractures without any surgical exposure. The questions we are going to answer in this lecture, I hope I can answer these questions. Is it possible to speak about closed reduction of the femur and tibia in adults? If you are a 46 years old man with a fractured femur, can we speak about treatment with closed reduction at all? I don't think the people will believe in this. Can you reduce the fracture without anesthesia or without analgesia? Can you imagine that you can reduce the fracture without giving the patient, for the adult, you cannot give without anesthesia or even analgesia or light analgesia? Can you reduce the fractures post-operatively or during follow-up in the outpatient clinic? Can you reduce the fracture if you find an axial malalignment or rotational malalignment 2 or 3 months after the operation? Can you correct the deformity without anesthesia, without taking the patient to the operating theater again? Classify the fractures of the long bones of the lower limb in adults into recent fractures or neglected fractures or infected fractures. Why infected fractures? Because if you revise the literature, nobody speaks about infected fractures. They speak about non-union, infected non-union. But if you have a fracture, open fracture for 35 days or something, how can you classify it if you have infections? We are going to talk about the infected fractures. What's the problem of the reduction? The main problem is soft tissue interposition. The second is the muscle spasm. You have a femur in adult, so you have strong muscles. Also, you have bone loss sometimes. Bone loss, if you want to reduce the fracture, it's very difficult to get anatomic reduction. So we're going to speak about recent fractures, neglected fractures, and infected fractures. Again, if you have a soft tissue interposition in the neglected fracture, this is an absolute indication for open reduction. Why? This is logic. You have contracted muscles in between. It's quite logic. I know it's logic, but there's no proof that you have to do an open reduction. And if you look to literature, if you look to the slide, somebody says so you have to do an open reduction immediately. Sometimes you've had an overlap for 5 centimeters, 6 centimeters, 10 centimeters. You have to do skeletal traction for some time, perhaps for 2 or 3 weeks, or you have to do an open reduction, then a skeletal reduction, traction, then internal fixation. So you have to do 2 or 3 stages. But you have to end up with the same conclusion: open reduction and internal fixation. everybody is swimming the same way, the same direction. I wonder why. Now I'm going to give you an example of the closed reduction techniques that I'm using. You know, as a simple-minded surgeon, you know, I'm less than average surgeon with simple-minded. I'm going the way that I'm treating the fractures. The first one is the manual distraction, no severe distraction. Almost in most of the cases, we don't use femoral distractor. Or you put the frame on the femur and the tibia and you do strong distractor. Sometimes strong distraction displaces the bone. Again, in most cases, you don't need just manual distraction and the manual reduction. After you do joint aspiration, you can use your thumbs to reduce the fracture. The frame positioning. Very simple way to treat, to do closed treatment, to put your frame vertical to the bone. Just to put it vertical to the bone. Then you use just some sort of distraction. And if you do some sort of distraction, if you get the two rings parallel to each other, you can get reduction. Very simple. So during application, you just put your frame vertical to the bone. And when you get your proximal and distal parts of the frame parallel to each other, you get reduction. Very simple way of doing things. And this is an example. Fracture, recent fracture of the distal femur. And we are going to apply the proximal segment here, and the distal segment here, vertical to the bone and vertical to the bone. This is vertical to the bone. And when you move it and you have two rings parallel, you can get anatomic reduction. Again, and this is the axis of the distal femur, axis of the proximal femur. They are going to meet each other in the cora or the fracture sites. And we are going to put our hinges here to correct it. The closed reduction techniques are using olive wire for the intra-articular part of the fracture. In this comminuted fractures, we use just simple traction, simple manual traction, and you can get anatomic reduction of the articular fragments. Then you put an olive wire from one side, another olive wire from the other side, without any tension. Another thing, another important issue, many of the people think that they have to tension the olive wires. This is not true. In most of the cases, you don't need to tension the olive wires to gain reduction. Again, the arched wire technique. And I'm going to give an example of the arched wire technique. In this case, tibial plateau fracture had been treated by double plating. But you see the bone gap. It's about 1.2 centimeter bone gap in the sagittal plane. Look to the bone gap, a big bone gap. When we removed and it is infected fracture, we removed the plates and we used the arched wire technique. One wire in this posterior segment, and we pushed the two ends anteriorly, and one wire in the anterior segment, this anterior segment. One wire posteriorly and one wire anteriorly. The anterior wire, we bend it posteriorly, and we tensioned both of them at the same time. So we had closure of the gap, closed the closure of the gap. And despite this patient has too long incision, we didn't use the incision for reduction. We used, because I know the surgeon before me, he used the two incision, but he failed to attain reduction. So we used the arched wire technique to have closed reduction. Now the second issue, can you reduce the fracture after the operation? We know that you can reduce the fracture during the operation. We all know this. But I'm going to talk about a different thing. You can treat the patient after the operation. You can reduce the fracture after 1 week. 2 weeks, 1 month, 2 months, 3 months, as long as you don't have consolidation of the fracture site. You can do gradual coronal translation, gradual sagittal translation, gradual angulation, gradual rotational and translation, axial distraction or lengthening, and axial compression. I'm going to give you an examples. In such a patient with floating knee, he had a fractured tibia and fractured femur, comminuted fractured femur. And the patient had external fixator. And after 2 months post-operatively, we always do long film after the operation. But as you see here, we had varus deformity 2 months after the operation. If you draw the mechanical axis from the center of the hip to the center of the ankle, you see the mechanical axis is medially deviated from the knee. So we have crystal clear varus deformity. And this is 2 months after the operation. How are we going to solve this problem? We have a varus deformity. So we analyze the deformity. We analyze the deformity. This is the site of the cora. If you do the mechanical, the axis of the proximal femur, the distal femur, we are going to have, this is the mechanical axis of the proximal femur. This is the mechanical axis of the distal femur. They are going to meet in the cora. So we have our cora here. It's exactly on the fracture site. So the cora is on the fracture site. Then we are going to put the hinges, one hinge anterior, one hinge posteriorly. As you see, this is the site of the hinge. The site of the hinge is exactly on the cora. So we have the cora, acca, and osteotomy at the same point here. So this is osteotomy rule number 1. And then we'll put the distractor here. And we gradually correct the deformity or the varus deformity. So we can correct the coronal malalignment 2 months after the operation. And you see here, we applied osteotomy rule number 1, and we corrected the varus deformity. And this is the mechanical axis afterwards. During follow-up, after 2 months, 1 week, 2 weeks, you can do gradual coronal plane transmission. And in this patient, after the operation, we had translation. So what we do temporary, we put temporary rods between the proximal and distal parts of the frame. Then we change the frame onto this construct. And we move the distal fragment medially because we have lateral translation. And we'll move the distal fragment from here 1 millimeter per day. So we can correct the coronal plane translation. Now, after we corrected the coronal plane translation, we found out that we have still sagittal plane translation. The distal segment was a bit posteriorly, so we decided to do sagittal plane translation. So we changed the frame again, 90 degrees. So we moved this fragment 1 millimeter per day. Now, after we did that, we had angulation. So we changed the frame again. We put hinges, 2 hinges. This is the acca, the hinge posteriorly, and we had a distractor in the middle. So in the same patient, we did coronal translation, sagittal translation, and correction of angulation. Another advantage of closed treatment, that you can use the closed fractures as a corticotomy. You know, we all know corticotomy. And the Russian people, they advise that if you do corticotomy, you have to do a very small incision, not to disrupt the soft tissues or the blood supply outside the bone or inside the bone, periosteal or endosteal or something. But what about if you have a closed fracture? We can use the closed fracture as a closed osteotomy. This is the best. You can get the best results. So if you have this patient with the fracture at the site here of the regenerate. We put the frame and we waited for a couple of weeks. Then we did distraction 1 millimeter per day, and you see the regenerate, 10 centimeter regenerate. So you can use distraction osteogenesis and fractures in closed, and use the fracture as a closed osteotomy. Sometimes you have a trauma and you have bone loss, as you hear. You can do corticotomy in the proximal part again with the fracture, and you can do lengthening at the same time and the closure of the gap. What about the soft tissue interposition? You know, it's the golden rule. If you have soft tissue interposition in neglected fracture, you have to do no production. It's a golden rule. It's basics. You cannot say the opposite. So look here, if you have soft tissue interposition, this is a neglected fracture femur in this adult, and you see that you see here, you have severe posterior displacement. What we do if we have a neglected fracture with soft tissue interposition, we do some distraction first, as you see here. Then translation, we translate from posterior to anterior. You see the translation, this segment was posterior, we pushed it here. We draw the mechanical axis of the proximal femur, mechanical axis of the distal femur. They are almost parallel because of the translation. It's a big translation. Again, the proximal and the distal, it's coming closer here. Now, as you see here, we did before. And this is distraction. This is over distraction. We pushed the segment to the opposite way. It was posterior. Then now it's anteriorly. This is overcorrection. Why overcorrection? Because I want to get sure that there is no soft tissue interposition, that I moved all the soft tissue. And this is the key. If you want to do close treatment of soft tissue interposition, you do some distraction, then translation, then over translation. Afterwards, we treat this as a deformity. This is the axis of the proximal segment, axis of the distal segment. You are going to meet in the cora. We put distraction one side and we correct the deformity. Look here, this is anterior. Now we have it anatomical position. When we get to the anatomical position, we do compression. This is close treatment of neglected fractures. Some people say this is basics. What's the evidence that in neglected fractures with soft tissue interposition, you have to do a no production? There is no proof, just hypothetical. People talk to each other. Now I'm going to give you a few examples. This is surgical exercise. If you are with me now in the operating theater, and I will show you some exercises after I finish this example. Usually we do post-operative long-standing film, exactly like you treat a deformity, because you want to measure the mechanical axis deviation and leg length inequality. In this case, we have comminuted fractures. We have valgus deformity. Look to the mechanical axis, the axis, it's lateral. So you have to correct the axis. And now you have another long film. We have corrected axis. Again, we have shortening. If we have shortening, we do some compression, then distraction to correct the length. Now, if we speak about close treatment of fractures, we talk about operative reduction of fractures, post-operative reduction of fractures in the outpatient clinic without anesthesia, without analgesia. But you can mix both. You can do operative and post-operative. Operative, especially for intra-articular fragments. And post-operative for the diaphyseal part, especially with the neglected fracture, which is almost impossible to gain anatomic reduction during the operation. From my experience, sometimes, for long-standing fracture for 2 or 3 months, it's very difficult to gain anatomic reduction because of the soft tissue interposition during the operation. But you can gain anatomic reduction of the intra-articular part. This is a recent tibial plateau fracture, comminuted distal plateau fracture. You see 3D fracture, comminuted fracture. See. And look to the soft tissues. People say that you can put temporary external fixation and you will get the healing of the soft tissues for 10 days or something. But from my experience, sometimes you have 1 month before healing of the soft tissue. There's no guarantee. Now, we start the operation by aspiration of the effusion, then manual distraction. Look to my thumbs here. I use my thumbs to do manual manual manipulation. This is the 2 thumbs here to do manual manipulation and the manual distraction. We almost have anatomical reduction of the articular segment. Forget about the diaphyseal part. We have anatomical reduction of the after anatomical reduction of the articular segment, you have a big gap. Look to the gap, something like 6 centimeter gap in the metaphysis. We put the first wire, an olive wire from one side, another olive wire, without any tension, Now we have almost 1 fragment. We change the situation from multiple fragments to 2 fragments. This is 1 fragment and the diaphysis is another fragment. Look to the lateral, we have anatomic articular reduction as you see here. Again, we have a huge bone gap, 6 centimeters or something. Again, we put 2 wires again for the stability of the proximal part. See another stability. Then we apply the frame proximally and distally. We have a displacement of the fragment. We do translation using an olive wire of the distal fragment. Then look to the lateral view. Of the lateral view, we have an evident gap and we have rotation of this. You see it's a bit, the fragment here is extended. So we put the frame vertical to the bone. Then we move it in the sagittal plane till we get very good reduction, as you see here. But with the reduction, you still have a bone gap. So we almost have acceptable reduction here, but we still have a 6 centimeter gap. So we did closure of the metaphyseal gap. We did closure, compression for the 5 or 6 centimeters. When we did compression, we lost some reduction, no problem at all. Then we have a waiting period for a couple of weeks, not less couple of weeks. If you have a comminuted fracture and you are going to use it as a corticotomy and you are going to lengthen from it, we do latency for 2 weeks. Then we do gradual distraction to compensate for the leg length inequality. You see the bone formation, and this is the magnified gap. Look to the bone formation, excellent bone formation in the gap. So you can treat, even if you have a gap, you can treat the gaps in a closed manner. Another example, recent distal femoral fracture, comminuted fracture with intra-articular. And you are going, this is an example of operative reduction. I'm going to give another example of the post-operative reduction. Again, knee joint aspiration, manual traction, and the manipulation using the thumbs. We apply the frame proximally, and this is distal traction, mild traction, and we use the thumbs to induce reduction of the, till we get anatomic reduction of the articular fragments. Forget about the metaphyseal part, then we put 2 olive wires, we build the frame on the distal part, then look to the lateral, totally displaced. It's totally displaced. How are you going to solve this fragment? You see, this fragment is flexed, you have a bone gap, and if you do compression, you have more displacement. You see the flexion here. So what we do is distraction, We did distraction. Then we used the arched wire technique. We just put an arched wire in the posterior segment. This is an arched wire, you see, in the posterior segment. Then we tensioned the arched wire. When we tensioned the arched wire, we arched the wire anterior and tensioned, we closed the gap. And we induced compression. You see, we closed the gap. Total closure. You see the posterior cortex. And this is the same patient. You see, we have after long film after the operation, 2 weeks after the operation, we have a valgus deformity. We corrected the valgus deformity, as I told you, and this is the end picture. The patient is 76 years old, diabetic, uncontrolled diabetes, hepatitis C positive, cardiac problems, but this is closed treatment of fractures. This is an example of operative and post-operative treatment or reduction. I will give you 2 examples. This is one of them, comminuted fracture, and this is another one with the horrible, and you see the overlap. It's about 12 centimeters or more overlap. Now we have an intra-articular and extra-articular fracture. Again, during the operation, we treated the intra-articular part, multiple olive wires opposite each other. And this is post-operative X-ray, see. Total displacement of the diaphyseal part. Don't talk about the surgeon and say he's a lousy surgeon because the patient came out because I'm the surgeon and I can hear you, okay? So are we going to solve this problem? We did gradual displacement, medial translation. You see the displaced fracture. Anatomic reduction of the articular part with displaced diffraction of the metaphyseal part. We did gradual coronal translation till we had almost anatomic reduction. You see, this is before, during, and then compression by side to side. Because you have a short oblique. If you have a short oblique, you cannot do axial compression. If you do axial compression, you got to have shortening. So it's side to side compression. Now the lateral again, this posterior, push it anterior, then overcorrection with magnified picture, overcorrection. Again, you treat it as a deformity, and you have anatomical reduction and compression. Anatomical reduction. Close anatomical reduction 2 months after the operation. Again, this patient present to us after 1.5 months with this picture. You see the overlap. I'm sure that there's some soft tissue interposition, contracted soft tissues or something. You see here. The patient went out operating theater with this picture, just some sort of distraction. Then we started more distraction, as you see here, then translation, coronal translation. And we finished the coronal translation, we corrected the deformity, then we still have in the lateral. You see the lateral view after distraction and overcorrection, you see anatomic reduction. We don't speak about acceptable reduction. We speak about anatomical reduction. You see the picture here, the lateral and the AP and lateral and union. Again, because of the gradual correction, it seems like we have a very good callus. Of course, we did the same thing for the tibia. You see the callus formation. And this is postoperative. You see this. And this is the last case, infected fracture in a polytrauma patient. You have an infected fracture which had been treated by debridement elsewhere, and you have comminuted fracture femur, double level fracture femur, and also open comminuted fracture of the tibia. Both are terribly infected, both of them, and presented to us about 20 days after the operation. And you see the wound. There was an open wound in the femur and the tibia. And this is the technique we use. I've learned it from the Russian people. We use multiple wires, 2 or 3 or 4 millimeter wires with serrations of the tip. Many serrations of the tip. You can use too many of them. You see them. Then we developed here the cannulated half pin. It looks like a DHS or something. We augment these wires with this. These wires can help you to close the gap. This is an operative reduction. We started with the proximal part, then we closed it, then we used the frame here, and we treated the distal part again. And the tibia too, we corrected the displaced fracture of the tibia. And you see the union here. Again, this is close treatment of fractures. And the patient had rotational flap at the same time by the plastic surgeon. In conclusion, displacement of long bones fractures in adults can be considered as a deformity, which can be treated by deformity correction principles. The real merit of the use of the circular fixator as a definitive treatment is closed operative treatment of fractures. This is the real merit, because I don't see that in the literature. They speak about the external fixator as a temporary measure. Even during the discussion of the external fixator, nobody talks about the way you treat the fractures, the way you reduce the fractures. Nobody talks about the post-operative treatment of fractures. No, it's there. You can treat the fractures post-operatively. So gradual post-operative reduction during follow-up is also possible without anesthesia, without analgesia, no problem at all. Soft tissue interposition can be treated by gradual distraction, over reduction, followed by anatomical reduction in the compression. I'm sure you can gain anatomical reduction, not acceptable reduction. I think that's enough about treatment fractures as by closed methods as a deformity. Now we can move to Dr. Sharma, then we will have discussion afterwards. Dr. Sharma is going to speak about another clinical topic, the fixation, the deformity assisted correction by fixation. Professor Sharma. Yes.
Thank you so much. Just 1 second.
Okay.
So thank you so much, Professor Hosni. I have to say that was very comprehensive, one of the forgotten arts of reduction with the hinges and putting them in the principles from the form and the fractures is quite critical, because that is a bulk of the work. And I have to say, in the Western world, with the hexapod coming in, people have forgotten how to put hinges properly. And that's very comprehensive. Fantastic talk to relearn them. I think we should send some of our trainees to you for a few months every so often to learn about hinges. So I'm going to talk about, I've been asked to talk about fixator-assisted deformity correction. What are basic principles? And I'll give you some examples of the so sneaks as well. So just now the question is, why do, sorry?
Connection is unstable.
Right, can you hear me?
I can hear you now, yes. But the connection is unstable.
But as long as you can hear me, it's okay.
Okay,
Yeah, but
that's
the
fine.
voice, yeah.
Now it's fine.
Okay, so so why we have to do internal fixation? Because one of the things about this is it's much easier for all fixation, but it could uncomfortable to patient. And other problem is joint stiffness. Is particularly important for femur because femoral frames, because of the muscle bulk, are not where pins leak a bit, but even more important is it is very uncomfortable for patient. And one of the advantage of this is that you can individualize each internal fixation after considering needs. Depending on that, you can identify and do an individualized treatment. There are a number of things we need to consider. And a most important thing I've highlighted in right that use the soft tissue condition, how much deformity you're going to correct, and the most importantly, the translation which you will have. And as Professor Hosni alluded last week, the osteotomy rules and how important they are important when you are putting in internal fixation. Now, principally, osteotomy are of three types. So you can have an opening wedge osteotomy where you leave a gap. You have a closing wedge osteotomy, you have to take a piece of bone out, so the bony contact is better. And then a dome osteotomy, it is a hinge which rotates on another circle. So this is a completely different, and is by convention, open and closing wedge osteotomies are most commonly used. However, dome osteotomy has some fantastic advantages apart from being very stable and very good bony contact. Now, one of the things about is it is usually the osteotomy which determines what implant to use. Now, one of the things what we can do is we can use the rule 2, shift the osteotomy to accommodate the implant. That way, it gives us an advantage that we can use the implant which is better for the patient. So as long as you understand the principles of the deformity correction, understand the osteotomy rules, we can do this. The other very important thing we need to consider is the neurovascular bundles or the soft tissue. Where is osteotomy? How far is it from the neurovascular bundle? And if you're going to do an acute correction, how much nerve will stretch or the artery will stretch? And what are the complications for that? What is the effect of that? And there are geometrical formulas to calculate the stretch on the nerve depending on the distance, whether using the femur or the tibia, and how far is the neurovascular bundle. But we must remember that all these calculations are for normal soft tissue. The soft tissue which is previously operated, scarred, is very different, and the soft tissue tension is different, stretching is different, and therefore a nerve and artery injury can be much more easily done in which is much more damage. Then how much we can correct? That's again a question of debate. 25 degrees as an acute correction, and anything over they will do gradually. Sheffield did a study and they corrected up to 45 degrees of acute correction. About a third of that is in multiplanar correction. But they did mention that if you are lengthening the leg, then the correction should be limited to 30 degrees. In general, the general belief is that up to between 20 or maybe up to 30 degrees is the maximum you should correct. Anything else you should do with gradual correction. And this a nerve was released, had an acute correction of the femur and a gradual correction of the tibia with the circular frame. Now, what implants are available to us once we have corrected it? For the metaphysis, plates are easier, although nails can be used because metaphysis is broad. So, because we must remember that our entry point with the nail is different, and therefore, use is quite easily as well. However, for the diaphysis, if you're going to use the nail, then it must be the osteotomy rule number 1, and the correction should be done at Cora, as it any translation, then you can use the nail. Then how to improve the accuracy of the correction? So there are a number of ways you can do it. One, you can do a fixator assisted. Then in addition, you can use the computer navigator assisted deformity correction. And what you do is you use a total knee replacement track. There is no purpose-built platform as yet, but if you use the total knee software, it will give you a very accurate mechanical access on the table. But we must remember, it is a static access. We must ensure that the dynamic component of the deformity, intra-articular deformity, and all the dynamic component of the deformity must be included. Only then we can get an accurate correction. The other way to do it is we do a 2-stage procedure. So in stage 1, you put an external fixation, you correct the deformity, and after 4 to 6 weeks time, when it's all corrected, in static and dynamic components are corrected, you take the patient back to theater, you put an internal fixation, and the disadvantage, it ends up with 2 surgeries, and infection rate is a bit high, but it's very, very accurate. And the most important thing is it addresses both the static and the dynamic component of the deformity. We must always remember that translation is almost always there. And this obligatory translation has to be addressed whatever implant you're using in your stabilization. Now, where can you put your pins? If you take the sawbone model, if you're going to put in a nail, anteriorly there's a plenty of tibia, and you can put your wire, your half pins, everything in front, and still do a nail. If you're going to do a nail, your pins posteriorly, and still you can put a nail across from there. If you're going to use a plate, then put the pins on the opposite side and use the and then use your pins in the front or back. Really doesn't matter. And this is an example where if you see there's a bit of translation. Rule 2 is used, and as Professor Hosni pointed out, these pins are perpendicular to the proximal segment. These pins are perpendicular to the distal segment. You make them parallel. Your deformity is corrected, and you put in your nail inside. You must remember the entry point of the nail is not the standard, it is different. In femur, if you're going to nail it, then you put your pins posteriorly. If you're going to plate it, then put the pins on other side. Now, this is another example, what Professor Hosni pointed out. This is perpendicular to this segment. So we must remember this is anatomical axis at 81 degrees. The pins has 10 degrees on. You put parallel to this, you correct it. You parallel, your deformity is correct. But you see your entry point of the nail is different, right? This is a rule 2, and there's an obligatory translation in this. This is an example where you put your first wire, you put the second wire 10 degrees to the, because your anatomical lateral distal femoral angle is 81 degrees. You correct it, and then this is the correction with the LRS, and you put in your nail, and there's the corrected bone. So what is available? You can have support assisted. You can have TSF TLX, which is the most commonly used. They're expensive, time consuming, and I will only recommend it for very complex deformities, otherwise not. Then you have standard Eliezer of hinges, and a fantastic example was given by Professor Hosny in his previous talk. If you apply the same principles into this, you will never go wrong. You can also use a monolateral. It is much more harder. Advantage is much cheaper, much easier to use, and we don't need any specific training because we use it all the time. Just 1 second. Khalid is calling me. Hi, Khalid. Hello? Khalid? So do you want me to speak loudly?
Yes, please.
Okay. Let me try it again. Just 1 second, hold on. Let me just double check the connection. 1 second, I'll be back.
Okay. Yeah, because the connection is unstable.
He's checking with his son.
As usual.
Okay, just 1 second. Let me move it down to near the modem, and that might help. Sorry, 1 second.
Somebody is loading videos.
Must be my son. 1 second. Okay, is the voice any better?
Yeah, this is better.
Okay, sorry about that. I don't know what's happening. It has been playing up all afternoon. Now, apart from Elizarov hinges and the monolateral frames, which is available to us, you can use a system called Unico, which is very new, uses unicortical pins. But again, it's expensive and it is something new. The biggest advantage is it takes only about 10 to 15 minutes to put on. That is the biggest advantage. Apart from that, I think a bulk of the work we do is with Elizarov hinges. Now the principle, again, I'm going to just reinforce what Professor Hosny said. You put your fixation perpendicular to the respective segment. You plan the osteotomy, put the hinge at the osteotomy, you check your alignment, correct it, and stabilize it. These are the simple 4 steps, and actually it's very simple as long as you follow these principles. So what you have to do is whenever you're correcting this, so here if you see I have put in a hinge here, this ring is aligned to this segment and this ring is aligned to this segment. Now in theater, you're marked, you can plan, you can take your time because this is the most important bit. As long as you align the limb, align the frame according to each segment, put the hinge at the right place, you'll be fine. And here, this is the sagittal view, if you see. And what I've done is I've left the space here for my plate and hinges at the osteotomy. These 2 segments are aligned. And this is, it takes some time, but this is the most important step of the entire surgery. So let me show you how I do it. So this is the leg. I have marked the leg. This is the joint line. This is the distal end of plate, which I measured. I'm going to put. This is where I'm going to do osteotomy. And I measured how far is the plate coming, 6-hole or 8-hole plate, whichever I'm going to use. And so I marked it. So my pins should be proximal to this. So when I put the plate, my pins should not be in the way. Then I make my fixator, I put my hinges, I align them, put in through. And if you see, my proximal ring is proximal to the proximal most part of the plate. The advantage of this is I'll put my pins here, and if I have to extend the plate or even the same plate, then I'll be out of the way. Here, I always leave the space for my plate because I'm plating here. If I'm putting in a nail, then I'll plan the frame in a slightly different way. Here I have put in a pins. So this is my 8-hole plate finishing here, 2 pins here. I've also got some computer trackers, total knee navigation trackers, which I've used, one in the distal segment, one in the proximal segment. This is the medial view. So I've left the lateral side open. All my 2 pins are here on the medial side. So 2 pins there, 2 pins here, and that leaves me all this space to cut the bone, to correct it and straighten it. Then, so this is a closing wedge osteotomy. So I put 2 wires, cut the pin, take a wedge out, and I correct it. And once I've corrected it, I put in a plate. If you can see, there is a plate there, and my hinges are there. I check my alignment with the diathermy, with the total knee navigation system. And this is before I close. So this is the size of the scar and the leg is straighter. I've checked it. This is just a sawbone example just to reinforce the point. So if you see, this is my cora, but I'm going to do osteotomy slightly higher, right? And so this is my alignment. I've checked the plate. My plate is finishing here. So my pins should be proximal to this. So I put in a hinge, again the same way. This is my hinges on the cora, but my osteotomy would be proximal. So I'll be using rule 2. So I put half pin there, half pins on this side. That leaves my medial side lateral side all open on this side. Then how to do a dome osteotomy? This is what I mentioned earlier. So what I do is I put in a half pin there, then I put in a rancho, and I slowly rotate the rancho. And with each rotation, I put in a drill, and I make a hole. So just to show you again, so you put in a rancho and you keep on rotating on this pin, and it will give you lovely dome osteotomy. So once you have done the multiple holes, you take a small osteotome, and you connect it, a small one, sharp one, and then you rotate it. So that's my cora, but my osteotomy is here. So this is rule 2. If you see, my hinge is now straight, and if you see, the whole alignment is straight, the bone is straight now. And here, I tighten the hinge, I've corrected. All I have to do is just put in a plate now. I hold the plate with 2 wires, check its position, put the screws there, come out. Now this is a short plate. You should try to put a longer plate, but sometimes it's not possible with the fixator assistant. So you can use a shorter plate. You put in screws, and that's your angle. We are finished. How you check the intraoperatively mechanical access? So there are 2 methods. So this is a distal femoral osteotomy for the lateral compartment OA. And the plan is to overcorrect this patient. So you put a diathermy, long rod, whatever, center of the hip, center of the ankle, should pass from the center of the knee. And in this case, a bit medial, because I wanted to put it medial, because I wanted to overcorrect it. This is a computer navigation software. So preoperatively, my axis was 60% on the lateral compartment. Once I corrected it here, this is what I want. I want a 30% medial, because I want to completely offload the lateral, because it's completely grade 4 and the patient was very young. Normally you correct to the center in the lateral compartment OA, but this one I just overcorrected it. So from valgus, I put the patient in about 3 degrees of varus. So on the table, I can check this as well. So this is the pre-op. We corrected that, healed, and this is the axis where I wanted it. So this is a method you can do intraoperatively, correct it, and get the desired result. Then what is a unico? Unico is a unicortical pins, and all you do is just very quickly drill it. It takes you 5 minutes. It's a so this is a patient where it's got distal femoral valgus, very, very bad deformity, and we thought we're going to put it and correct it with the distal femoral osteotomy. You can do an opening wedge, you can do a dome osteotomy. Domes are much better and much nicer as long as you have taken the translation into consideration. So how we plan it? So again, every operation should be planned the same way. You plan your osteotomy, you plan your plate, everything. And then once you've done that, I've done my a dome here. I put in a half pin. I've done this dome. Doesn't look very pretty, but I promise you it's a dome osteotomy. And these are the marks which I used. This is my patella. I've done all that. So once I've done that, I put the unico. Now the advantage of unico is it just goes to the one cortex, and it takes you literally, you just drill it. It has got a torque holder, torque restrictor, and it stops on its own. So you drill it in about 5-10 minutes. You put the whole fixator. You have to put 4 pins minimum on each side. So 4 pins here on tibia, 4 pins on femur. You put it. You do your osteotomy. You correct it, and this is the intraoperative. I've done the osteotomy, and I'm trying to correct it. I haven't put my rod. So once, if you see, there are 4 pins here and 4 pins here, and I'm using the diathermy to check my alignment. And at the same time, once I know where it is, I put in a rod, and then like any fixator, one person holds the leg, other person tightens it. It works similarly like LRS. You tighten it, and this is your correction. Once you've done it, and I've also used the computer navigation, you put in a plate and you finish it off. And this is the pre-op. This is the post-op picture. From axis is in the middle where we wanted. This is the pre-op picture, and this is the post-op picture. This is corrected. Other thing you can do is a 2-stage procedure. So this patient with a high tibial osteotomy, young patient, he said, I like internal fixation, but we discussed the options. So we decided 2-stage because he wanted an accurate correction, but he didn't wanted a frame. So this is what the planning was. So this is the fixator. And if you see in the fixator, the important thing is there is nothing on inside here. All the pins are on lateral side. And what you do is, and there is nothing here. Now, if you see, I use an orthofix ring which comes 5/8 and 3/8. So you put the 3/8 of the part of the ring on this side here. So what happens is so when you correct it, you stabilize it here, take the 3/8 ring out, and you have plenty of space to put your fixator, right? Sorry, your internal fixation. You take it out, you put your plate in, and we need to ensure that internal and external fixation do not touch each other. That will decrease the risk of infection. So you put that on. You put the plate in. It's translated. You put the plate on, and this is healed. He's quite happy because he didn't have to have a fixator long term. The disadvantage of this is it is of internal fixation. Its surgical time is increased. In some patients, you will have a rebound phenomena because the muscles are too strong, and you correct it, and when you finish it, it is undercorrected. It is because of the muscles are too tight or too robust. And since you can only have one chance to correct it, so it's important that we get it right and correct it spot on every time. So this is an example where I put a fixator assisted deformity correction, and this is the during the operation. If you see, I corrected it here, but when I finished it, if you see, it's undercorrected. It rebound, and the reason for that is he's a young chap. Muscles were too strong. In these cases, I think putting in a double plate or using a fixator or a nail may be a better option. So just need to be careful a little bit. In summary, I think it's ideal for all the metaphysical deformities and some diphysical deformities. The most important thing is you must ensure that whatever internal fixation you're using, it is compatible with your external fixation. Means they have enough space for each system, because you put in one system and there is not enough space. So for example, you put an external fixation and there's not enough space to put your nailing jig, then you are in trouble. And similarly, you put in a fixator, you put in a plate. If your fixation pins are in the way where your plate is supposed to be, that would be very difficult. So leave enough space for whatever you're using. It is very, very important. This is the most critical step. The other important thing is the preoperative planning is crucial. You need to plan it, everything, and then you must follow the principles of deformity. And if you follow that, then you know where your translation is, how much correction you're going to get, and it's easier to put an implant. You only have one chance to correct it. And after that, what is corrected is corrected, and then nothing you can do after surgery. Thank you so much.
Thank you, Professor Sharma. Now we move to the questions. Think, Liz, the first question for you. May I know what are the steps and sequences of clinical rotational profile assessment?
Yeah, please do correct me, Hemant and Gamal, if you disagree, but I really still struggle with this. Still, you know, my heart sinks a little when I realize a patient's got a rotational deformity and I might have to accurately assess it because I'm thinking of operating on them. The first thing I would say is looking at the patient walking and looking for their foot progression angle, because ultimately that's what matters to the patient. I'm not aware that rotation in itself gives any problems with long-term increased joint wear. We do know about the problem with the patella and subluxation with malalignment, but ultimately it doesn't, you know, it's more about how the patient feels when they're walking and how cosmetically how it appears. Then I always ask the patient to lie prone and I look at the tibial torsion, because I find looking at the thigh foot angle is the most, for me, accurate way of assessing that. And femoral torsion, especially because some of it is within the femoral neck, I do struggle with. So I would assume, for the purposes of planning any deformity correction, that if there's an element in the feet, in the tibia, which I can measure with the thigh foot angle, but that is different to the foot progression angle when standing, that the difference must lie within the femur. Now, it's also then pretty rare that I would do a deformity correction on both the femur and the tibia. So your next question is then, can you correct and achieve a normal foot progression angle or a symmetrical foot progression angle just through correction of one bone? So that's also why it matters less the absolute measurements within the femur and the tibia. All of that is then complicated by a very valgus deformity, a very varus deformity, a varus hindfoot, a valgus hindfoot. All of these things make it even harder. And also, if you can, correcting the hindfoot whilst looking at the thigh foot angle is useful. But yeah, it is really hard, and there's certainly no simple radiological way that I can explain either. And it's just, again, when you look and you see on those X-rays, oh, that hip doesn't look AP yet the knee does. You know that there's deformity in the femur, and vice versa for the knee versus the ankle.
Okay, it seems like the rotational problem is really underestimated. One of the journals sent me a paper about the rotational deformities after interlocking tibia in level 1 trauma center, and they described the incidence of rotational deformities more than 10 degrees after interlocking tibia is more than 36%. And when I saw the review of the literature, it's not less than 30%. Can you imagine the number of people suffering from rotational problems after just interlocking tibia?
Mm-hmm.
So it seems this is the real issue, which is really underestimated in the literature.
Yeah.
I think
Yes.
I will just add to that. I think Dr. Mulder has has described it very well. Femur is always hard, but I think the important thing is a lot of these deformities, we need to be pragmatic about it. That what needs correcting and how much needs correcting, because the aim is not to get everything 100% like a normal patient, but the important thing is that can we correct this leg where patient can walk normally without any long-term problems or any compensation which can cause long-term problems. If we can avoid that, then perhaps that is the best way to treat a patient. And I think that varies with the individual patients, their problems, what their expectations. And luckily, femur has got good range of motion, so they are less obvious, and TBI are much easier to correct, fortunately.
A question about the treating intra-articular fractures using external fixation as a definitive method. Does not that interfere with the clear concept of achieving absolute stability in intra-articular fracture? No, no. We give an absolute stability of the intra-articular part. We have two olive wires opposite each other, then we add other wires. So for the intra-articular part, it's absolute stability. There is no contradiction. Another question. How to determine the amount of distraction needed? It's easy. When you do a long film, postoperatively, you can know the amount of distraction needed. And after you finish the distraction, you do another long film. So if you are mistaken in the first X-ray, you can change it later on because you do gradual lengthening. Yes. They asked me to answer a question in Arabic. I will do that, but after I teach Les and Professor Sharma Arabic. You need some time. Perhaps, Hemant, the last question for you. How do we decide between lengthening over nail and the plating after lengthening? What are advantages and disadvantages of each? Lengthening over nail and the plating after lengthening, advantages and disadvantages.
Okay, so lengthening over nail, we have stopped doing it because of the higher risk of infection. If you remember the literature, the deep infection rate was up to about 37%, which is very high. So Robert Rosbrook has popularized the concept that nailing after lengthening, right? So what you do is, the most important concept in all these situations is that you need to plan it before, because so you put your external fixation pins and wires in a way that your internal fixation device, whichever one you're choosing, do not touch the external fixation pins, so your risk of infection is fairly minimum. So ultimately, I think it depends what you do. There is not enough literature to suggest which is better in terms of long-term outcome or complication rates, because the both techniques are relatively new. But nailing after lengthening is better in the sense because it gives you an internal splint and it is a load sharing device. So healing is generally appears to be better. Plating after lengthening is not a load sharing device, and therefore you got to be more careful with it. Your incision is much bigger, although you can do minimally invasive plates. But ultimately, it depends what you're trying to do. In the peri-articular problems, usually plating is better. Anywhere where you can, anything more in the diaphysis, nails are better. So I'm sorry, I haven't given you the straight answer. It just depends. You have to use according to the appropriate condition and the site of the bone.
Okay, question, Liz. May I know how do we choose between opening wedge osteotomy, closing wedge osteotomy, and dome osteotomy?
Okay, well, I would say opening wedge osteotomy is technically probably the easiest and good if you've got a shortened limb to increase the length, but you've got to consider whether you can get a stable fixation and a decent hold on that bone. And certainly with a frame, doing a gradual opening wedge osteotomy, and as you were showing in your slides, growing that bone, distraction, histiogenesis, as you distract and open it up, is the simplest and easiest way to get an osteotomy. Closing wedge is good for stability, but you have to be more accurate and it would be acute. But it is good for then probably facilitated weight bearing and easier to hold. And then dome osteotomy, if you can make your dome close to the cora, and it's very good in metaphyseal bone, very nice and stable, and more length neutral. So, you know, there isn't a favorite really. It very much depends on each individual case that you're doing, the patient and how you want to fix it.
Okay, perhaps this is the last question for Hemant. Is it fine to bend pre-contoured anatomical plates in case of translation to make it fit properly?
Pre-contoured plates are designed to be off the bone. So you do not have to bend it further to fit the bone because they're designed for it. However, there are times where there's a bone spike coming out because of translation and your plate is sitting 2 miles away and you feel very uncomfortable, and you can sometimes cheat and shave the bit of a bone at the edge and just make it fit better. So we all have done it. But if you have to bend it, yes, you can bend it. It's very hard, but you can bend it once. Otherwise, if you bend it more than once, then it becomes a problem. A, you lose the shape, and B, from the metal fatigue point of view, it's not ideal. So ideally not bend it, but if you're desperate, yes, you can.
Thank you. I think this is the end of it. Finally, I would like to thank Dr. Liz Mulder and Professor Hemant Sharma for participating in this symposium.
Thank you.
I would like to thank also Christine from MASH Premier Company for supporting the scientific events of the Egyptian Orthopedic Association. I would like to thank all the participants, and we are looking forward to see all of you next Monday, 29th June. Okay, yeah. Thank you. Have a good evening.
Thank you very much.
Shukran.
And have a good night.
Thank you, Professor Dr. Jamal and Dr. Sharma and Dr. Elizabeth. Thank you very much. Next Monday, inshallah, and 29, the last session, and fourth session, yes. Thank you, Dr. Jamal.
Thank you.
Bye-bye. Thank you. Thank you.
Thank you.
Thank you. Bye-bye.